Welcome everyone to ESC TV here in Barcelona. I'm Theresa McDonagh and I'm a clinical heart failure cardiologist from King's College Hospital in London. And it's my pleasure today to interview a global trialist superstar, Scott Solomon from Boston, who yesterday presented for us the results of the DELIVER trial, a trial of dapagliflozin in patients with heart failure with preserved ejection fraction and those with mildly reduced systolic function. It was obviously one of the great highlights of yesterday. There wasn't a lot of time in the hotline to ask questions to Scott, so we have that opportunity today. I do and you do as well, so please interact with us later on. I think to start off with, I suppose what I want to ask Scott is to tell us the main things from your point of view about DELIVER that we should be thinking about. Thank you.
Well, thanks, Theresa, and it's great to have a chance to chat with you informally today after the hotline session yesterday, which was very exciting. DELIVER was the largest and most inclusive trial yet in heart failure with mildly reduced or preserved ejection fraction. And I say that because we enrolled, of course, a wide range of patients with an ejection fraction over 40% in heart failure, and we included patients who were either hospitalized or ambulatory, and we also included patients who had a previous left ventricular ejection fraction under 40% that had improved to over 40% by the time they were enrolled in the study. A group of patients that had been excluded from all other studies. So we think that this is a unique population. As you saw yesterday, we saw an 18% overall reduction in the risk of a composite outcome of cardiovascular death or worsening heart failure being either a heart failure hospitalization or an urgent heart failure visit. But most interesting was that benefit was true regardless of where these patients were on the ejection fraction spectrum. And we think that's really important because there was some uncertainty about whether there was attenuation in the benefit with SGLT2 inhibitors like we had seen with other drugs as ejection fraction goes up. We saw no hint of that at all. There was benefit regardless of ejection fraction. So we're very excited about these results.
Yeah. In terms of the results, obviously they were similar in terms of magnitude and effect to the Emperor Preserve study, which reported at this meeting last year with empagliflozin. What do you think are the main differences, apart from the recovered group who are in DAPA, between the two trials?
I think that there are more similarities between these trials than there are differences, and that's great because it tells us that we now have a totality of evidence for SGLT2 inhibitors. As you saw, not in my presentation, but in the final presentation of the session yesterday, when you put these together, you see very robust benefits, again, across the spectrum of ejection fraction. That hint of attenuation that was seen with rising EF in Emperor, we didn't see it, so now I think it's pretty clear to most of us that was probably the play of chance in that study. Now, there are some differences, of course, in the patient population. We did include the improved patients. We did include patients who were more recently hospitalized and even in hospital. We saw benefit in both of those groups that was similar to the overall group, but I think that tells us that this is a very robust therapy.
Yeah. So obviously the majority of the effect was, or the statistically significant effect was seen on worsening heart failure events. And there was a trend to a reduction in cardiovascular deaths, which we also saw in Emperor Preserved, but it wasn't statistically significant. Now, obviously, we come from this world of HFrEF trials where we expect to see all-cause mortality reduced, cardiovascular mortality reduced, people immortal, living forever with wonderful quality of life. And the HFpEF trials have kind of moved us into a different way of thinking. So can you tell us a bit about the cardiovascular deaths, non-cardiovascular deaths, and what you think about the lack of reduction in deaths?
So 21% reduction in worsening heart failure, and then a 12% non-significant reduction in cardiovascular death. But let me be really clear about this. The event rates in heart failure with reduced ejection fraction for cardiovascular death are about twice as high as they are in heart failure with mildly reduced and preserved ejection fraction. The event rate for cardiovascular death goes down as ejection fraction goes up. When we look at the event rate in DAPA-HF and you compare it to DELIVER, it was about double for cardiovascular death. These trials are not powered individually to assess cardiovascular death. If we want to see cardiovascular death in these trials, we have to either make them much larger or we have to follow these patients for longer. It takes longer time. In fact, we've looked at what is the median amount of time between a heart failure hospitalization and a cardiovascular death in a HFpEF patient compared to a HFrEF patient, and it's over twice as long. So we just aren't doing the trials long enough or big enough to be able to show that. But as you saw again in the meta-analysis, when you put Emperor, Preserved, and DELIVER together, you come exceedingly close. I think that you saw yesterday the upper confidence interval of cardiovascular death in the combined analysis was 1.00, p-value something like 0.052. So that tells you if you have enough power, you will see a reduction in cardiovascular mortality. Now, you won't see a reduction in non-cardiovascular mortality generally with drugs like SGLT2 inhibitors. In fact, most of the drugs that we use in heart failure, because they really don't modify non-cardiovascular death. And people die of other reasons. In HFpEF, as you know, lots of comorbidities. There are other reasons that people do die. And if we can't modify them with these drugs, we're always going to see non-cardiovascular death that we simply can't modify. So we'd have to do very, very large trials to see an all-cause mortality benefit.
Yeah, and obviously reduction in heart failure hospitalizations is extremely important for patients with heart failure, and arguably more important in the HFpEF range when we're looking at older patients, where we're thinking really more about quality of life, especially at the very high ages rather than length of life. So I think that is very, very important. In terms of mechanism of action of the SGLT2 inhibitors, obviously phase 3 randomized outcome trials don't give us a lot of insight into that. Do you have any, I mean, this trial was done on a very high background use of loop diuretics. I think it was 77%, which is fairly standard for HFpEF populations. I suppose the HFrEF trials, you're usually up at the 85 to 90% loop diuretic, but you were at 77, which is really good. And you had a very high use of MRAs. So I assume you're not thinking this is a diuretic effect?
You know, obviously there are some diuretic and natriuretic effects with these drugs when you give them certainly early on, but no, we don't think that these are primarily diuretics. I'm more and more convinced the more studies that we do with drugs that we don't really understand the mechanisms. I mean, do we really understand exactly why ACE inhibitors or beta blockers work?
No.
After all these years, we are 8 years now from the presentation of Paradigm. Do we truly understand why sacubitril valsartan works? I'm not so sure. We tell ourselves stories. There's a lot of good science to understand, but I think that the fact that these drugs do work on top of very good background therapy. Now, of course, there isn't definitive background therapy in heart failure with mildly reduced and preserved ejection fraction. But this was the highest use of mineralocorticoid receptor antagonists, and we didn't see any in patients who were on MRAs. We don't see any attenuation of treatment.
So obviously we now have good evidence for the use of dapagliflozin in this population as well as empagliflozin, and as you say, we don't have the same worries about sequencing drugs that we have to think about in HFrEF or lack of sequencing of drugs, because we don't have the same evidence for disease-modifying therapies in HFpEF. So what's your clinical advice to us seeing patients with HFpEF or mildly reduced ejection fraction about, do you just start the drug in everyone?
Well, these are very, very well tolerated therapies. And I think, after this, with the data from both Emperor and Deliver, I think we can say that across the spectrum of ejection fraction, we probably, if we believe the patients have heart failure, we should be using SGLT2 inhibitors. They're so well tolerated. I'm perfectly comfortable starting them in these patients. I think the neurohormonal agents probably tend to peter out as you go to higher ejection fractions. It looked like it was true with MRAs from TopCat, even if you believe there's an effect from candesartan in the CHARM study, and then with sacubitril valsartan, where we, in the US, we have an indication for use in this population. It does appear that there's attenuation as you go up, and there may be something fundamentally different in the way, sort of therapeutic heterogeneity as you go up in ejection fraction. But so I would start with an SGLT2 inhibitor in those patients.
Very reassuring to see the safety endpoints yesterday. There were really very low side effects with these drugs, and nothing that cardiologists tend to worry about, like diabetic ketoacidosis or arms or legs falling off or anything like that. Which was very reassuring. And also starting it in hospitalized patients, because we had that fear of doing anything when someone was sick and giving a drug which might be associated with the hyperosmolar.
I've never really understood that fear, because it seemed to me that in a hospitalized patient, especially after they've been stabilized, that has to be the safest place to start new drugs. But I think the data that was published also yesterday in the Journal of the American College of Cardiology on that particular subgroup, which has a lot of the safety data that I didn't present at the hotline session, is incredibly reassuring about the use of this particular therapy in the hospitalized patients.
Okay. Well, I've probably said enough, so it would be really good to get some questions for the audience, which you didn't have the opportunity to field yesterday, Scott. So, we have a question here. Okay. I think you've probably got to go to that microphone in the middle, actually. Yeah. Can you tell us who you are as well?
Thank you very much, Kaiser from Rio de Janeiro. I think this is a particular subject that you've mentioned partially. Vast majority of your patients were on beta blockers. We know that now SGLT2 inhibitors really seem to be foundational drugs, irrespective of ejection fraction, but we know that many patients with HFpEF do not tolerate or do not even need beta blockers. So what's your vision about this particular class of drugs and HFpEF now?
It's interesting. We've seen now in many trials about 80% use of beta blockers in patients with HFpEF, and I don't understand why. I saw Carl Swedberg standing on the back of the room, and maybe we can blame him for this, but I honestly don't know why we see so many patients on beta blockers. There is no definitive data that they're actually helpful. There's obviously chronotropic incompetence in many of these patients, so they could get into trouble. I think we need to really think that, but my understanding is that the guidelines recently have taken a a dim view of beta blockers in heart failure with mildly reduced and preserved ejection fraction?
Well, we gave them a class 2B, level B recommendation with all the other drugs for mildly reduced ejection fraction. I think the problem is they're on them for other reasons. The patients have prior myocardial infarction, ischemic heart disease, atrial fibrillation, and used for rate control. Yeah. So I think you probably find it's the way they got to the heart failure that has brought the beta blocker with them, rather than people starting them in patients with mildly reduced or FPEF.
But to be clear, they're probably not necessarily treating the heart failure itself.
No, exactly.
Other things, right.
Okay, sweet. Thanks.
Do you think that recommendations are going to change and move to 1A after delivery?
You're going to have to ask Dr. McDonagh that question, because she's the guideline person. I mean, I think we have, as she said yesterday, there is certainly sufficient data now in my mind to move this class to a 1A recommendation, but I have to defer to the guideline.
Yeah, yes, first of all, one trial never usually changes a guideline, but two trials certainly should. The question is how the guideline committee, of course, which it's a consensus, it's not my view or Scott's view, how they view the strength of the evidence. We have two huge trials here that both met their primary endpoints. You would be astonished if they didn't come up with a 1A indication for these drugs in mildly reduced and preserved ejection fraction for a reduction in cardiovascular deaths or hospitalizations. But also guidelines committees in the past have been tended to go towards mortality benefits. So let's see. It's an open space.
Thank you. Thank you.
Yeah. Okay. Next.
Thank you very much. The primary endpoint was driven primarily by reduction in hospitalization for heart failure. So I think it's important to clarify what percentage of total hospitalizations were related to heart failure. And the second very short question, how about renal outcomes?
Okay, so what you're asking, what percentage of the total heart failure, total hospitalizations were due to heart failure? I can't give you the number off the top of my head, but this in a heart failure population, it's going to be a fairly large percentage of the patients. You know, remember, drugs like this are not going to prevent COVID hospitalizations or other hospitals generally. I mean, maybe there's some magical effect, but people get hospitalized for other reasons, and SGLT2 inhibitors are not going to help those.
So I'm asking this because HFpEF patients are polymorbid patients, and in Emperor preserved, only less than 20% of hospitalizations were related to heart failure. That's why I asked. Thank you very much.
A lot of comorbidity in this population, there's no question. They are going to be hospitalized for other reasons, and generally we're not going to modify that with these drugs.
Yeah. So, I mean, I think that the trial's very conclusive. We've seen SGLT2s reduce morbidity and mortality in HFrEF and in HFpEF and have mildly reduced ejection fraction. Do you think there are any gaps that still need to be filled in your mind, or have we just covered the whole spectrum?
Yeah, I mean, there are always gaps, and right now the major gaps in SGLT2s, we will get more data in the patients with the sort of subacute, those who are hospitalized and stabilized. There are some trials going on. I think we have some data now from DELIVER. In the post-MI setting, there's a gap.
Yeah.
And, you know, we've actually seen that SGLT2s are beneficial for heart failure prevention in patients with diabetes, but we really don't know if that would be true in patients without diabetes, although I think they might be. So there are always gaps, and more importantly, there's residual risk. These patients, we didn't cure heart failure with this trial or any other trial. There's still a very high event rate, even in the patients who received the SGLT2 inhibitors. So we still have work to do.
Time for probably one last question. Yeah.
Okay. Congratulations, first of all. And you've mentioned the benefit regardless ejection fraction, and I wanted to know your opinion. because when you see the curve, it seems that patients with 60% of ejection fractions benefit like a little bit more than patients with 50. So I wanted to know your opinion about that.
So, when we look at this statistically, we see that it really suggests there is not heterogeneity. If you look at any subgroups in clinical trials, you're all going to see a little bit of variation. In Emperor Preserved, it looked worse there. In Deliver, it looked a little better. If you put them together, it looks pretty flat. So I'm pretty convinced that there is no heterogeneity with ejection fraction.
If you're quick, there's one more question.
Okay, thank you. What about acute heart failure and the dapagliflozin?
As I said, in the stabilized patient in the hospital with heart failure, we have some evidence from Deliver. There are other trials that are ongoing looking at this patient population. So I think that we should feel at least comfortable in the stabilized patients that these are beneficial.
Okay. So I think, if it's very quick.
Congratulations for your study. You are going to publish in the near future the renal outcomes data.
We were very fortunate to publish 11 papers yesterday with Deliver, and that wasn't one of them. And the reason is the American Society of Nephrology is coming up in November, and we're going to be presenting some renal data there, and we will hope to publish those data at the same time. So stay tuned.
Well, that's good news. I think cardiologists find it difficult to cope with EGFR slopes and reduction, so I'm glad you focused on the mortality and the heart failure endpoints. So it just remains for me to say, Scott, absolute congratulations to you and John and the Deliver team for a fantastic trial, and one that will change our clinical practice for treating patients with mildly reduced preserved ejection fraction and improved ejection fraction heart failure. So thank you very much.
Thank you, Theresa.